Hello, everyone, and welcome. Thank you so much for joining us this afternoon. My name is Benjamin Quinn, and on behalf of Harvard Bookstore, I'm so excited to welcome you to today's event with John Abramson, discussing his book, Sickening, How Big Pharma Broke American Healthcare and How We Can Repair It, in conversation with Dr. Helen MacDonald. Today's event is part of Harvard Bookstore's Friday Forum series, which takes place on Friday afternoons during the academic year as a way to highlight scholarly books in a wide range of fields. Though we remain digital for the time being, we have a full schedule of virtual events in the coming weeks as part of this afternoon series and others. For today's event, we will conclude with some time for your questions. If you'd like to ask the speakers something, locate the Q&A function wherever it may live on your Zoom display, where you can submit all your questions. We'll get through as many as time allows. Please note that closed captioning is available for this broadcast. Depending on which version of Zoom you are using, you may need to enable it yourself. Simply locate the button marked CC Live Transcript on your display and click through the options. If you go to the chat function of this presentation, I will shortly be posting a link to our website where you can purchase your copy of Sickening. Your purchases and financial contributions make events like today's possible and help ensure the future of a landmark independent bookstore. Thank you all for showing up and tuning in support of authors, publishers, indie bookselling, and the brilliant scholarship this series showcases. And now it is my sincere pleasure to introduce today's speakers. John Abramson has been on the faculty of Harvard Medical School for 25 years, where he teaches healthcare policy. His previous book, Overdoses America, received rave reviews from the Washington Post, Publishers Weekly, and elsewhere. In addition to many academic articles and op-eds in the New York Times and other publications, Dr. Abramson's work has appeared on Today, CNN's American Morning, NPR's All Things Considered, and the CBS Evening News. Today, he is joined in conversation by Dr. Helen MacDonald, an editor for the BMJ, an international general medical journal. Since joining the BMJ, Dr. MacDonald has commissioned, edited, and hosted and podcasted a wide range of academic and less formal content, and has worked on the BMJ's campaigns and conferences on overdiagnosis, medical excess, commercialization, and the production of better evidence. This afternoon, Dr. Abramson and Dr. MacDonald have joined us for a discussion of John's latest book, Sickening, an illuminating look into the dark underbelly of American healthcare, which Catherine DeAngelis, editor-in-chief emerita of the Journal of American Medical Association, calls a scholarly tour de force that should be read by all prescribers, researchers, publishers of that research, and users of pharmaceutical drugs. As one of the foremost experts on the drug industry's deceptive tactics, John Abramson brilliantly combines patient stories with what he learned during many years of serving as an expert in national drug litigation to reveal the tangled web of financial interests at the heart of the dysfunction in our healthcare system. I will end with final words of praise from James M. Wright, who remarks, "To improve Americans' health, a large proportion of the US population must read this book and incrementally reverse this travesty. When that happens, it will improve the health of the rest of the world as well." We are so excited to be hosting this event today. Without further ado, I'm now delighted to turn things over to our speakers. The digital podium is all yours, John and Helen.
Woohoo! Hello. Hi, everyone. I'm Helen MacDonald. It's a real pleasure to be with you. I'm coming to you from the UK where I live. I live in the southwest in a city called Bath, which is very old. It has Roman baths in it, and then it got taken over by the Georgians. So it has very lovely architecture. And you may notice as we talk that the sun is going to go down. So I'm going to get dark in the background here because it's nearly nighttime. And you guys are hopefully perhaps thinking of enjoying some lunch. And I hope that John and I can bring some enjoyment to that middle part of your day as you head into the weekend, talking about his book. And there are some massive themes in here for us to discuss. Access to data, commercialization, a bit of history of health and healthcare in the US. And before we start, and I feel that I should definitely say this because of the theme of John's book, I have to declare my interests. And I don't have any particular commercial interests other than I am an employee of the British Medical Journal. That's what BMJ stands for. It's an international medical journal. I also trained as a GP, so I come with that perspective. A GP is a family physician equivalent in the UK. And I've got an interest in writing and in editing and in evidence-based medicine, which is one of the themes that John touches on in his book. So that's enough about me. That's all you need to know about your questionnaire. What we're going to do the rest of the time is learn more about John and more about John's book. So I think we've got about 40 minutes to do this. So let's get started. I thought what we'd do is find out a bit more about John, find out about his book, and then hear your questions. So that's our vague arc of the next 40 minutes or so. John, you've got an awful lot of titles that Benjamin introduced you with at the beginning. Do you want to sort of recap for us a little bit why you are well placed to write on matters of US healthcare and what goes on behind the scenes?
Sure. And thank you for moderating this, Helen. I really appreciate it. I too am a family physician, GP in the UK, family physician in the United States. And I finished a residency in family practice. I had served in the Public Health Service in National Health Service Corps in West Virginia. And after finishing my residency, I did a 2-year Robert Wood Johnson Fellowship in which I learned about statistics and epidemiology and research design, was headed for an academic career, but changed course and decided that my calling really was to be a physician in a small. My Robert Wood Johnson Fellowship education and went and practiced family medicine 20 years in a small town about an hour north of Boston. And I opened that practice in 1982. As we got towards the late 90s, it became clear that there was increasing commercial intrusion in the information that was reaching us practicing physicians through even the most respected medical journals. And in 2000 and 2001, the issue of Vioxx, an anti-inflammatory drug that was supposedly safer than other older anti-inflammatory drugs came up. It was highly touted in an article by the New England Journal of Medicine, and then touted again in a review article by the New England Journal of Medicine. And I realized in reading the review article that we weren't getting all the information and that there was a clear danger of cardiovascular risk with Vioxx, and it provided no better pain relief. So I started to pursue that. And there was an article in JAMA a couple of weeks after the review article in the New England Journal. It led to an FDA website that had some of the data that Merck had submitted to the FDA. And it showed that Vioxx was clearly a dangerous drug, that it more than doubled the risk of cardiovascular disease, heart attacks, strokes, and blood clots. And at that point, it was clear that we were being practicing physicians, were getting bad information, and that I had the tools from my Robert Wood Johnson Fellowship start to dissect this, and decided to leave practice and write a book about what I knew, what I could find out from public sources as a family doc. And that led to Overdosed America being published in 2004. I was extremely lucky in that Vioxx got pulled in the biggest drug recall in US history. It's a week after the book came out. Suddenly I was all over the TV on Today Show and many other national shows. Lawyers saw me, and they saw me translating science into English, and they thought I might be a good person to serve as an expert in litigation. And that led to about 10 years of work in national drug litigation. And in that work, I got to see what's inside the corporate computers. So when we all think, gee, I wish I really knew what was going on, as an expert in litigation, you can find out what's going on. And I could bring that work to the FBI and the Department of Justice in one case that participated in a fine that was the largest criminal fine in US history against Pfizer for misrepresentations about Bextra. And I participated in a federal district court trial where Kaiser Health Systems sued Pfizer for fraud and racketeering, and they found them guilty of racketeering. I spent about 10 years in litigation. Much of I got to find out what was happening, and some of this information was unsealed, but it wasn't changing anything about the way doctors understood how the commercial compromise of the integrity of the information that they were receiving through their trusted sources. So that led me to the decision to write Sickening, to explain it to physicians and to the public how much the information they're relying upon to guide their practice of what they think is optimal medicine, how much of that is controlled by and corrupted by the pharmaceutical industry. And that book took me about a little more than 5 years to write, to get the story down to 230 some pages, so it was understandable, and the book had an arc. And it was published February 8th, and here we are, Helen.
Wow. Well, you're trained, aren't you, when you're a GP or a family physician, that you're not meant to ask questions while the person says what's wrong with them initially. And I feel like we gained an awful lot of information by just letting you talk there. That was quite an introduction, and what a huge journey to go on from being a medical student to being a practicing clinician, into the courts, thrust into the spotlight of the media. And I wonder, all that experience, you are the same person to some extent underneath all the time through that. I wonder what sort of drives you as a person. You told us a lot about your experiences, but how did you feel beneath all of that when it was going on?
Yeah, beneath all of that, I felt like I had gotten a hold of the tail of something that was really wrong in American healthcare and to some extent internationally. And my path had led me to this finding, and that it was that I just had to pursue it. I had no choice but to pursue it.
So you sound like quite a dogged person. You're not going to give up once you make a decision to go.
Yes, my friends and former friends would certainly agree with you.
And you draw on various wise people in the book. There's some really interesting quotations from historical and modern figures in there. And I noted one quote near the beginning of the book from John Adams about no holes barred and no room for being polite. Do you think that's necessary? Do we need to be kind of shocked?
Yes, and we need to be fortified. I think when we get a hold of a story that is important and not understood by the public and not understood by many experts, we've got to be willing to be impolite in the way that physicians have to kind of be impolite to drug reps if they don't want to get exposed to their spiel about selling a particular drug. There is plenty of rejection of critical ideas. And if one will get through, one has to be willing to cut through the resistance, which can involve being sometimes overly dogged, but to keep focused on what we're talking about.
And when you started this book, what was your focus there? Did you start knowing where it was going to go? Did you have in your mind what you wanted to do with it?
No, I had I had an enormous amount of information and could have written a 1,000-page book pretty quickly. It wouldn't have had much of an arc, but when the editor, Alex Littlefield at what is now HarperCollins, started to work with my initial ideas about how I was going to present all this information that I had learned in litigation to make the case that Americans are being ill-served by our current healthcare system and method of producing knowledge. When I got wind of that, and sent Alex my initial notes, he did a wonderful job of gently getting me to see that the story needed an arc and it needed to be told in a way that would draw readers in. So without that coaching, it would have been an unreadable mess, I think.
Well, interestingly, I was about to compliment you on your writing, but maybe I should be complimenting Alex, your editor. I don't know. But you do seem to have an ability to draw these different worlds together, the medical world, the legal world, to speak to the public, to draw out individual stories and weave those things together, and that's quite unusual. I mean, I edit a lot, and doctors and academics, many of them are not good writers. Where do you think your ability to write and tell engaging stories comes from?
I think I don't think I can answer that question because I don't believe I have an ability to write. I have an ability to work hard and to stay with an issue. But I had a lot of help along the way. Patsy Shepard was a wonderful personal editor for me, and just being dogged about, I'm going to tell this story. I have been privileged to be in this position. I was privileged to be a family doc. I was privileged to be in litigation and see what's really happening, to have the tools to query 20 million documents to figure out what really happened in each situation. And that I had a responsibility to tell the story, and I was just going to work until I got the story told.
Okay, I think we should turn to some of the story then. So you begin, there's quite a bit of scene setting at the start. You need to know quite a lot about US health and healthcare. There's quite an emphasis on that at the beginning. And I think you feel that your reader needs to get some of those essentials and the vulnerabilities in those systems in order to then go on to these examples and make sense of them. So I don't know, you've cut it down from 1,000 pages to about 300 or so. Now you've got to cut down about 300 pages into 3 minutes.
236, Helen, please.
Okay. See if you can cut down what we need to know about the US health and healthcare into about 3 minutes for us. Give us the essentials.
Well, I can give you the essential very quickly. Most of what doctors know or believe they know about how best to take care of their patients has now been taken over by commercial interests. So 86% of clinical trials are funded by commercial interests. 96% of clinical research is about new drugs and devices. And the remaining 4%, only a part of that is devoted to how to improve the health of Americans. And in that context, we've got a disaster going on with American healthcare, a disaster that's even bigger than the COVID pandemic. We've got 1,300 people a day dying in the United States because the age-adjusted mortality of Americans is so much higher than the age-adjusted mortality of the citizens of 10 other countries. Our healthy life expectancy in the United States has gone down from 38th in 2000 to 68th in 2019, below Cuba, below China. And for that poor health, we're paying an excess $1.5 trillion. So this is destroying our country. It's taking, as our healthcare system is designed to extract as much money as it can from working Americans and transfer that money to investors. And that's really what the story is about. And my attempt is to explain how it is that that's happening.
And you say this book is about making the case, and in a way you approach it to some extent in a slightly legal way. You have some examples, cases, I suppose. There are lots, probably too many to talk about in this call today. What would you pick out as either the highlights or the kind of key themes that you learned from each of these cases?
So the first section of the book is 4 different cases. I talk about 4 different drugs or classes of drugs. And there's a theme in each one. The first one is Vioxx. 40 to 60,000 Americans died from taking Vioxx. It really got drilled into my radar screen when I got an email after a national TV appearance from a woman who said, please help us. Our 17-year-old daughter died, and would you look at the autopsy report and help us understand what happened? Well, what had happened is her family doctor had given the 17-year-old girl 8 samples of Vioxx for post-traumatic headache. And she later died of a massive stroke. That drew me into this issue emotionally beyond the intellectual pursuit I was on. But where that chapter goes is the role that the New England Journal played in not allowing the truth of that story to get out in time to save about 30,000 American lives. And the extent to which the New England Journal went to try to persuade me personally not to tell this story in the Harvard Medical School community. And I told this story because it's really important to understand that we think that medical schools are the place where truth is the guiding light. And that was my introduction to the idea that that may not always be the case. The next chapter is about Neurontin and how Pfizer convinced physicians that Neurontin was a useful drug to treat neuropathic pain. And the story tells of my testimony in federal district court in Boston, explaining to the jury the tactics that Pfizer used to mislead physicians. And the thrill it was for me to be standing right next to the jury box in this huge and intimidating courtroom, right next to the jury box with an easel, and to be able to draw on the easel how the results of a randomized controlled trial were perverted by Pfizer so that they claimed that the people who were treated with Neurontin were significantly better at the end of the study than they were at the beginning, when it was in fact a randomized controlled trial. And the question was not whether the people who took Neurontin got better at the end than they were at the beginning, but whether the difference between the Neurontin group and the placebo group was significantly different, and it wasn't. And there are more details and trial testimony in it, but the bottom line is that Pfizer was found guilty of fraud and racketeering violations. It was the first RICO charge. It's an American law, but it's designed to curtail the activities of organized crime and the mafia. And the jury to which I was speaking found Pfizer guilty of that. And that got very little press coverage in the United States, and most physicians don't understand why it was that the jury found Pfizer guilty of fraud and racketeering. And Neurontin, one of the most, gabapentin, it's now a generic drug, is still one of the most frequently prescribed drugs in the United States. The third chapter is about statins, and full disclosure for me and Helen both, we were she the editor and I the lead author of an article that was published in BMJ that showed that statins for low-risk people, meaning people without heart disease or diabetes or any unusual risks, provide very minimal benefits in terms of reduction of risk of heart disease. You have to treat between 100 and 140 people for 5 years in order for one to avoid a non-fatal heart attack or stroke. And the article was attacked, and the folks at Oxford who have all the data tried to have the article retracted, and the BMJ defended, or the BMJ appointed an external panel which rejected the demand for retraction unanimously. But it was kind of terrifying episode of having the most powerful people in the world attacking this article, and then having the BMJ appoint a panel that had the integrity to stand up to them. And the fourth chapter is about insulin and how we are wasting $20 billion a year prescribing the latest generation of insulin analogs, instead of recombinant human insulin, as is done in the UK as the first drug to provide insulin therapy for people with type 2 diabetes. And the chapter is really about how American physicians were persuaded to use insulin analogs based on claims that had originated with the drug companies and were carried through by the PR companies and were picked up by nonprofit organizations that make recommendations but accept money from drug companies, and how this sham has led to wasting $20 billion a year that we should be investing in helping people prevent getting diabetes and reversing their type 2 diabetes. So
that was a good run through.
Yeah, thank you.
I think that took us through a good 100 pages or so there, didn't it? So yeah. we had Vioxx and the hidden data. We had gabapentin or Neurontin and the marketing and distortion of particularly professional education. We had insulin and inflating prices. And I suppose what I wonder as an editor when I'm reading this, and this is often the case, I guess some of our listeners will think this, is this an isolated example, of all the stuff that goes on in the world? These are sort of just four cases. And you want to kind of make the case in this book that this is a general theme, that it goes perhaps, I guess, beyond those four cases is really, I suppose, what you're saying, because those examples are, of course, those things that went on to be proven legally are horrible. But you're trying to make a bigger point. So were there more examples that you could have put in here, or how do you address that kind of bigger question?
Sure. Instead of taking a vertical dive into each of these cases, let's look at the problem horizontally. And I present those four cases up front to set the stage for saying what's really going on here. And what's really going on is that the research itself has been taken over by the drug companies. So in the United States in 1991, 80% of research was conducted by academic medical centers. But that 80% went down all the way to 26% by 2004. So that means that the drug companies have control of designing the studies, of analyzing the data, usually of writing up the studies and sending the manuscripts to journals. And when they send the manuscripts to journals for peer review to determine whether they're worthy of publication, something that very few physicians understand is what we call peer review does not have access to the underlying data, so that the experts who are peer reviewing the articles have to rely almost entirely on the data that's included in the manuscript. So where physicians are being told that their standard is to practice evidence-based medicine, and that will bring them, that discipline will bring their patients the highest quality medical care, that evidence-based medicine hasn't been peer reviewed, and it's largely influenced by the commercial sponsors of the studies.
So you have these sponsors who have a commercial interest in this topic, submitting a selection of the evidence, and we're not able to see the big picture. And I love not only the way that you describe this in words in the book, but you have some nice pictures as well. And I wonder if you can describe in words one of your pictures, the iceberg picture, which if anyone's listening with one of John's books in hand, I think it's on page 118, though that may be inaccurate. I may have mistyped that as I was writing my notes before, but I think that picture really conceptualizes things very well.
Well, thank you. And you have to disclose, or I'll disclose the conflict of interest, because the idea for this picture came from the BMJ. And I had it redrawn. Peter Doshi gave me permission, and we went through and paid our rights and all, but and I had it modified. A wonderful lady, Darby Mumford, redrew it. But the picture is a sincere doctor in a little rowboat kind of vessel, and he has a telescope in his hand, and he's looking for scientific evidence. And what he sees is the top of the iceberg, and above the water, the part of the iceberg that's above the water, has the clinical, the articles that are published in medical journals that present what we call evidence-based medicine, and the clinical guidelines that are presented, that are compiled by experts based on those articles that are in medical journals, and then drug company marketing. And that's pretty much what doctors rely on for evidence-based medicine. But what's below the waterline that the doctor can't see with his telescope is the real data from the clinical trial. And the data is then compiled into what's called clinical study reports that are about 3,000 pages long. And they contain a lot of information. I think we could say 80 to 90% of the information of the raw data is included in those clinical study reports. Now, the key issue here is that the doctor can't see what's underwater, but there's no reason in the world why medical journals shouldn't require that clinical study report be submitted with the manuscripts that are submitted to the medical journals for publication. And once one gets adept at it, you can go through a clinical study report in 10 or 20, 30 hours, but it's not an insurmountable task. So we've got the information that will give 80 or 90% of transparency to the medical journals, and they don't use it. It's such a stunning absence of using material that's readily at hand. So you say, why don't they use it? And the reason I believe why they don't use it, and this came from Richard Smith, who was an editor at BMJ for 25 years and wrote this after he stepped down, is that the journals, especially the most prestigious journals, make a significant percentage of their income from selling reprints of clinical trials back to the drug companies to be handed out by the drug reps as marketing tools for the doctors. And if journals required the clinical study reports and curtailed the sponsor's ability to manipulate the data, it would make their reprints worth less. So we've got a market failure here. And the International Committee of Medical Journal Editors is unwilling to step in and say, we insist that all manuscripts that report the results of clinical trials include this clinical study report, so the peer reviewers can do the job that practicing physicians and the public believe they're doing.
Switching from journals to the clinicians, I'm really struck by how long you've been tracking some of these issues by the kind of length of your clinical career. And I wonder if you reflect on how easy it is to spot these things when they're happening real time in front of you. Because I think when you have access to all the information, when you sit down and there's a case going on and you're going to spend hours and days going through it, it can be easy to see things, can't it, in retrospect? Did you get the feeling when you were in practice that things were going on? How do you think either practicing doctors or patients in the public can notice when this is happening?
Helen, they really can't. It's a very serious problem. The light went on for me when I went to a grand rounds at my local hospital, and an expert from Boston gave a lecture about a drug, a pain relieving drug. And it turned out that drug had been withdrawn from the market 2 days earlier. and the expert came out to the hospital to give the lecture because he had a contract and he was going to get paid, but the drug had already been pulled from the market because it was causing serious adverse events. And I realized that the way that I was receiving information, going to grand rounds at my local hospital with my colleagues and getting a sandwich and being collegial, was just a way to transmit commercially based information to us. So I kind of got the drift that the system isn't working. But the real problem is you can't know it in real time because peer review, pre-publication peer review is not adequate to find it. And in the US, unlike the UK and most of the other wealthy countries, we don't have a formal mechanism of health technology assessment. So we have no organization that is telling physicians how new drugs compare to older drugs and whether they are of economic value, whether they're worth, the benefit is worth the cost of the drug. So US physicians are uniquely unable to get the information that physicians in other wealthy countries get. And we're pretty much at the mercy of the commercial interests. And the commercial interests, I just want to be very clear, they have one job, and their job is to maximize the profits they return to their investors. It's not to make us healthy. No matter how much money they spend trying to convince us that they're worried about our health, they're worried about the profits that they're returning to their investors. So this system, which is a pretty good system, a market-based system that distributes information and distributes goods and services, it generally works well. But for healthcare, it doesn't work because the consumers and the prescribers don't know the details about the products that they're using.
Mm. So I feel it's fitting, isn't it? I'm in a slightly dark place now. It's going dark outside. I've just had to turn my light on. Apologies for the slightly strange lighting that was going on my face there. And this is often the case. And I see this as an editor, that you often have people send you manuscripts, things that they've written about problems in the world. And I guess the really big question, and I think many individuals would like to make the world a better place or leave it better than they found it, is how can we make this better? And I was very encouraged that your book had a section looking to the future. Maybe that's very American as well, because you like a happy ending. And I like to hear a bit about, well, actually, maybe at first I'd like to hear how you have kept going, because it's quite draining, this kind of work, being in that zone, feeling like you're saying the same things over again, seeing the same patterns repeated through some of these cases. What has kept you going through those hard times?
And there are hard times for sure. I did the litigation for about 10 years. It is exhausting work, and it's like being a cage fighter, to go in deposition against the best defense attorney, corporate defense attorneys, and kind of burned out on it. But came out with this sense of obligation of that I was so privileged to have seen what's really going on, and that I had an opportunity to write a book that very few people, if any, could write. So that sense of duty, but it's sense of obligation to write the book is what kept me going, Helen. It took a lot longer than I thought it would. My wife was wonderful. We kept getting setback, and it took 5 years, a little more than 5 years to do it. But by that time, it was like the end of my life's work, and I had to finish this thing. Yeah.
It does feel like you've collected a life's worth of stories in here, a career's worth of stories, that's for sure. So tell us about this, what I'm defining as the more optimistic section of the book, about the way forwards.
So the way forward, I think, is pretty clear that
or your way forwards, the case you're making.
Yeah. democracy's not working. The American public knows that they're not getting a fair deal from the drug companies. More than 80% of Americans think that the drug prices are too high in the United States, and our brand name drugs cost 3.5 times more than they do in the other OECD countries. The American public believes that the drug companies are more interested in profits than they are in helping people, and that's absolutely true. And yet our politicians can't seem to get this under control. And it seems to be that it's correlated with many of our politicians, nearly all of our politicians, taking money from the drug industry. And it uncovers a flaw in American governance where there's so much disproportionate power and influence in the moneyed interests than there is in the people. So there's an opportunity here for the public to get involved in this issue in a way that would hopefully start to recreate a health commons, a healthcare commons that most Americans could participate in, commit to, because what's happening is that the public debate is being defined by the very small minorities on the ends of the spectrum of these issues. And the welfare of ordinary Americans, working Americans, trying to do their best for their families, is being ignored. And this could be an important rallying point for consumers. Businesses, it's a tripartite coalition that we need. Non-healthcare related businesses must get involved. They're paying a fortune. They're paying about $4,800 extra for each person, each family member that they're insuring. And American businesses are severely compromised in their competitiveness because of the enormous healthcare costs that they're burdened with. And finally, the healthcare professionals need to get involved. They can't practice. They can't do the professional work that they've dedicated their lives to. Healthcare professionals deserve to have thoroughly, independently analyzed analysis of the clinical trial data that is guiding their practice. So there are these three constituencies that are unable to meet their goals in different ways, different goals. But if they would get together into a single organization and say, we're not going to put up with this anymore. We're not going to be dissuaded from controlling drug prices by a pseudo debate amongst our politicians, that it's ruining our country.
So we have to address this problem with the evidence base, the access to it, the transparency of it, the independent verification of it. You want to see some kind of health technology assessment and independence included at that level. And there was another element, which I think you were speaking to at the beginning there, around the cost, and particularly the interface of that cost, not just with businesses and health insurance plans, but also with the Obamacare developments that have been happening in the US. Do you want to comment on how that interfaces?
Yes, the cost of prescription drugs has been brought out. Now we've got a Democratic president and Democratic control of the House and of the Senate, just barely of the Senate. So this would be the time to figure out a way to control drug costs. And yet the plan that we're not able to adopt would call for negotiation of such a small number of drugs that it would have barely an impact on the cost of new drugs. And in the process, the pharmaceutical industry is complaining that if any such program is implemented, it will quash innovation and the American people will pay an enormous price in their future, the efficacy of their future healthcare. The truth is that the calculations are that if the current plan were implemented, it would reduce the number of new drugs that are truly new drugs by about 10 in the next 30 years, we would not have 10 new molecular entity drugs over the next 30 years. But the reality is that only about a quarter of new drugs have been shown to provide previously unavailable benefit. So we would be missing somewhere around one new drug over 30 years if the current plan on the table were adopted. And it shows how powerful the drug company PR machine is to convince Americans, or at least to confuse Americans enough so that there's some fear about adopting this plan, which might cost Americans one new drug in the next few years.
Great. I've just had a message from Benjamin, which says, I have asked you enough questions. We need to turn to the questions from our audience. And so I'm going to keep one. I'm keeping one special question for the end, but here we go. We've got at least, I think I have 5 questions here, which is great. So you're going to have to answer each of these succinctly. I think I'm just going to go down in the order that they came in, which might dot us around, but it feels kind of fair to me. So the first question is, what is your opinion of Mark, I might say this name wrong, Cuban's new online pharmacy? That doesn't mean much to me as a UK person. I'm hoping this is going to mean something to you, John.
Yes, it does. So for Helen, Mark Cuban is a wealthy entrepreneur who is a sports team owner and is looking towards pursuing the entrepreneurial opportunity to provide prescription drugs on the internet with less middleman expenses. So a way to cut down the markups in new drugs. And my comment on that is I'm sure there's a good opportunity to save Americans money and for Mark Cuban to make a buck doing it. And I have nothing against that. Excuse me. The problem is it doesn't get at the core issue. It doesn't get at the core issue of what doctors know about the best drugs, the most effective and efficient drugs to prescribe for their patients. So it solves a little bit of the problem. And I would not dissuade people from using that service, but understand that we can't get from here to where we want to be by simply having discounted drugs on the internet.
That's useful. Okay, I'm breaking my own rule because that was a specific question. So I'm going to go to a general question and I'm going to come back to another specific question. So somebody writes, in between writing Overdosed America and Sickening, did your thinking about these issues change at all?
Yes, they changed radically. Overdosed America was based on what I could find as a family physician in publicly available documents. And oftentimes, let me clear up this. What I'm talking about is not that practicing physicians don't work hard enough to get at the data. There are some ways to get a little more data, but it's a systemic problem. It's not about individual doctors not working hard enough. So I understood when I wrote Overdose America that there was too much commercial influence going on, but I didn't know what was really going on. You can't know what's going on until you get into the hard drives, corporate hard drives, and you can look at what the scientists know and the interaction between the scientists and the marketing people, and the interaction between the scientists, the marketing people, and the executives, and with the PR companies that they hire, and with the expert physicians that they train based on their version of the data to go out and, air quotes, educate other doctors. Until you can see all these documents, you can't know how important it is to see the documents. You just cannot figure out what's going on without having access to those documents. And the litigation is not the way to solve the problem because it's 5 or 10 years behind real time. And it's so detailed that even, for example, when Pfizer was found guilty of fraud and racketeering in federal district court in 2010, it had very little impact on Neurontin prescribing. The way that physicians are taught to receive information, the paradigm that they're taught about where legitimate information comes from, is so ingrained that the docs aren't going to get it unless there's a way to provide better information through those sources that they have been trained are legitimate. And that's where health technology assessment needs to come in, independent health technology assessment.
Okay, that was a very interesting answer and an interesting question. Thank you for that one. Our next question, Patrick Radden Keefe published his wonderful book on the Sacklers last year, which seemed to galvanize many. Here, you write your own story of the pharmaceutical industry. Do you think focusing on the Sacklers is productive when it comes to understanding the problems we have?
Absolutely. It's a horrific story. And the details are just jaw-dropping. I describe the situation with OxyContin in maybe 10 pages. And what I do with OxyContin and Sickening is to show that it's not an unusual story, that it's ordinary journeyman tactics to market OxyContin as if it is safe enough to use chronic non-cancer related pain, as if it's not abusable, and as if it lasts 12 hours. And once the Purdue Pharma got those three key messages, they turned OxyContin into a great blockbuster drug. The only difference between the marketing of OxyContin and the marketing of all the other drugs that I talk about is that OxyContin is a uniquely dangerous drug, and it had a unique resonance with the socioeconomic plight of white, non-college educated men. So the effect was horrific, and it set up now a disaster with illegal fentanyl coming in to satisfy the needs of people who got a taste of an opioid high through the use of OxyContin. So the destruction that's been done by OxyContin is unique, but the marketing, the point I want to make in Sickening is a different point. It's they used the same journeyman tactics that are used in all of these drugs, and it has to do with misleading physicians. Purdue knew each of those three branding points, that it's safe, that it's not abusable in the last 12 hours. They knew those weren't true. But when the drug companies get a patent on a drug and can create a brand, it's almost as if they're getting a patent on an empty box, on what's inside an empty box. And the patent gives them a monopoly on the beliefs they fill that empty box with, whether they're true or not. And then the drug company can sell it and take it to the bank. And OxyContin was just another instance of these journeyman tactics.
We've got two more questions, John, on the chat. And one person's asked their question twice because I saw it pop up. So it's like someone's hand right at the back is going, me. It's definitely my turn. Maybe she missed my question, so I didn't. I'm going to come to that question next because it seems so keen. It's from Marcia, and she says, can you speak about the price of COVID vaccines? It's well hidden because none of us are paying for them up front, but indirectly we will eventually pay the price, and we're at the mercy of the companies making the vaccine because of the immediate need. Any comments on COVID vaccines?
Yes, that's a wonderful question, Marcia. And the price of the COVID vaccines, Pfizer priced its vaccine, they shadow priced, so it was the same with Moderna. And Pfizer claimed that it was going to make profit ratio margin somewhere in the high 20s on their first round of vaccine. Now it turns out that in 2022, Pfizer is selling its vaccine to the UK for about $30 per dose, and that it costs them less than $5 per dose. So they have an 83% profit margin on $32 billion worth of drugs that they're going to sell in 2022. And what we see with the vaccines is for Pfizer, they sold $37 billion worth of vaccine in 2021, and they're going to sell $32 billion in 2022. And the previous highest selling drug in the world was Humira for $20 billion a year. So we see the enormous amount of money and the enormous amount of profit. And what we see is that this is the vaccine spectacularly effective, and I would encourage everybody in the United States, everybody everywhere, to get vaccinated and boosted. And unvaccinated people in the United States have 20 times the risk of dying compared to vaccinated people, vaccinated boosted people. This is imperative that we use these drugs. But this too, like the OxyContin story, the vaccines are just another way for the drug companies to maximize their profits. And they're going to take as much profit as they can out of the vaccines. And it's a perfect example of how beautiful technology is being abused for profit. Because we've got in the US and I assume the UK, we have as much vaccine as we want. We've got our own problem with vaccine hesitancy, and I wish I could help people get over that. Excuse me. We've got as much vaccine as we want, but because the vaccine companies, particularly Pfizer, Moderna, and Johnson & Johnson, are so intent at maximizing the last dollar of profit they make, so that they're focusing their attention, their sales, on the wealthiest countries first. And the poorer countries are under-vaccinated. Africa as a whole has about a 16% vaccination rate now. The poorer countries in Africa have less than a 10% vaccination rate. So we've got these wonderful vaccines in the United States, where we are not sharing these vaccines with the rest of the world, and the variants are going to continue to be generated in the undervaccinated countries, and they're going to come back and hurt us. So despite having these wonderful vaccines, because the vaccine companies have been so greedy, these variants are going to come back and hurt us. And it's kind of like we built this very luxurious no peeing zone in a swimming pool. And we think that people who are privileged to swim in the no peeing zone of the swimming pool will be protected from the stuff that the other folks in the pool have to be exposed to.
I did wonder where you were going to go with that.
Yeah, and it doesn't work. If we're not going to be safe, we Americans are not going to be safe until the poorer countries have adequate vaccination rates, somewhere around 60%.
Okay. That was a full answer to that one, which is pressing us for time. And we still got two questions. I mean, I just wonder if you worked for a pharmaceutical company now, or you imagine that someone from such a company was sitting on the call, how do you think they would respond to the themes in the book? What would they say?
I think that they would appeal to the common wisdom that Americans are benefiting from innovation in a way that citizens of the rest of the world are not, because the drug companies are making enough money to continue to provide new drugs. There's a modicum of truth in that, and that the health of Americans keeps going as the cost of our drugs keeps rising further and further above the cost of brand name drugs in other developed countries. The health of Americans keeps going down further and further below the citizens of the other countries. And there's this kind of golden veneer on innovation, as if that's going to be our salvation, when in fact about 80% of our health is how we live our lives, exercise and diet and not smoking and community health. And about 20% is due to medical care. And some, but not much, is due to medical innovation. Now, the vaccines are a good example of medical innovation that works. So I'm not against innovation, but the way that innovation is stressed as the primary path to better health is a real disservice. And I think if yep.
that builds us a bridge, actually, John, to one of our other questions, which takes us from the tobacco industry to, takes us from the pharmaceutical industries, big spoiler there, to the tobacco industry and sugar industries. And Mary Lee asks whether you have investigated those industries and products.
That's a great question, and the answer is no. I've got all I can do to figure out what the pharmaceutical industry is doing. But let me say one thing that differentiates the food industry, fast food industry, food industry, and so forth, and the tobacco industry from pharmaceuticals. Pharmaceuticals are very complicated, and it's called a credence good. That when doctors prescribe a pharmaceutical product, they're trusting on the knowledge that has been passed on to them about the drug. They have to accept that knowledge. It's not like a new tennis racket or a computer where you know what the product is and does, and when you use it, you know what it is. Drugs are a credence product, and our system of developing that knowledge is broken, so that what's happening with sugar and tobacco is it's right out front. It's not okay. It's harming our health desperately, but it is what you see is what you get. But with the pharmaceuticals, it's hidden, and we need some mechanism of getting the truth about the pharmaceuticals to the doctors and the consumers so that they can make wise choices.
Okay. Changing tack slightly. There's a question here. As a practicing physician, this is not me speaking here. This is Regan. As a practicing physician who reviews articles for a few journals, I want to comment that the current structure for reviewing will need to drastically change if raw data from studies will someday be released to reviewers. Reviewing is a free service we volunteer to do, and to be expected to take time to run our own stats on the raw data is a big unreimbursed ask. Thoughts on if paying reviewers would help improve review quality?
Good question. I review too, and I'm sympathetic. I think that there's no way we can ask reviewers to analyze raw data de novo. We could ask journal-paid statisticians to review the clinical study reports, and like a dentist poking for cavities, see where there are weaknesses, where the raw data might be needed. And then if the analysis of the clinical study report and any raw data that's needed is done by an in-house statistician, it could then be passed on to the peer reviewers. Now, this will complicate the peer reviewers' life, and the peer reviewers are doing this voluntarily in their spare time, which they don't have. So it's a big problem. I think paying peer reviewers is a fine idea. You just have to make sure there's no conflicts of interest in those peer reviewers. And there's so much money involved with these clinical trials that there's plenty of money to pay people to do this job. So I agree that that should be considered, and having journals develop in-house capability of providing an independent analysis to the peer reviewers, who can then integrate that into their critique of this submitted manuscript.
Wonderful. I messed up one of the questions, which became deleted and has come back. Sorry, I found another one. Benjamin, do I have time to do this question that's here?
Yeah, of course. Yeah. Sorry, that somehow vanished.
Hold on. There's a vanish. Oh, I don't know which one to do now. Now I've got more. You're all warming up and we've run out of time.
Yeah. Sorry, everyone.
Hold on. There was a question. Oh, here we go. There was a question. I messed up Mary Lee's question, which started with the sugar industry, but comes on to a different point, which was around fluoride policies, and why people don't want to talk about them. Is that something you know about, John, or that you have a view on?
I don't want to talk about them either. I'm sorry, I don't. I'm not up to date on this, and I don't want to pretend to be.
That's fair enough. Sorry, we can't answer that one for you. Benjamin, that means I think I've got to the end of them.
Yeah, so I think that clears the Q&A. Thank you to everyone in the audience for such thoughtful questions and thoughtful engagement with today's material. Before we close off, I just want to let you two have any last minute words, anything you want to leave us with, John?
Yes, I want to thank Helen for putting in the effort to digest the book and ask such wonderful questions and be such a good sport. So thank you, Helen.
Oh, what,
And thank you to the listeners, especially for your interest in these matters.
Well, I will say thank you for providing us the book. And it's always a privilege to read someone's life work, whether you have listened to this and this has been one that chimes with the way that you think, or whether you've read it and listened to our conversation and disagree. I think the point is that John has made a very eloquent case, and I hope that it has inspired you and given you some thoughts heading into the weekend. Thank you, John.
Thank you, Helen.
And thanks to both of you for this fantastic conversation. Thanks to all of you out there for spending part of your afternoon with us. Please learn more about this incredible book and purchase your copy of Sickening at harvard.com. On behalf of Harvard Bookstore here in Cambridge, Massachusetts, enjoy your weekend, keep reading, and stay safe. Thanks again.